Okay, so those of you who have made it, thank you very much for coming to this breakfast meeting on healthcare, looking at it through a business lens. There's a lot on healthcare, a lot of chat on healthcare and health generally at this summit, more than I've known, I think, in previous summits. At last, the health profession is starting to get the idea that climate change is a very, very serious challenge to human health. And looking for solutions, and also looking for opportunities in terms of the healthcare industry. I'm thinking of what we're looking at in terms of health impacts. Well, heat is an obvious one. Are your elderly parents going to die in the next heat wave? General heat and debility, floods. Food supplies affected, both from the sea as well as from the land. I think often people forget about fishing, and obviously fish stocks are being very badly disruptive. We'll have new vectors of disease spreading around the world. We'll have refugees and sanitation. I mean, this sounds like a dreadful, dreadful list, and it is a dreadful list. And then we're on to things like that people don't mention so much, which is the loss of potential biomedicines through the loss of biodiversity. And there was a report out yesterday talking about the threat to hospitals worldwide from extreme weather events, knocking out power systems. I'd not seen that before. And there's another one as well, which is anxiety, people's mental health, particularly young people's mental health. I mean, I don't know about anybody else in the room, but I suffer from bursts of climate grief. It's what it's being called nowadays, climate grief. Just thinking, crikey, I've been reporting this for 35 years, and some irreversible stuff is happening now. I bumped into Jim Ski yesterday, the head of the Intergovernmental Panel on Climate Change, who I've known since he was a junior researcher at the University of Sussex. We're great pals. And he said, all the indices, all the indicators were pushing right up at the top end of what had been forecast. And sea temperatures were off the scale of what had been dreamt of. No scientist, he said, has predicted remotely what was happening with sea temperatures. So we are in a dangerous situation, but, with danger comes opportunity, and hopefully, the healthcare industry will be able to see a way that they can defend people somewhat from the ravages of climate change while also turning a profit. So we have a nice panel here. We've added somebody else to the panel, which is Lauren McCowan. Is it McCowan?
Yes, yeah? McCowan.
Yeah. So she was due to be talking separately, but we pulled her onto the panel because things have been a bit disrupted this morning, as you can see. So we're going to start with Robert Metzger, who's head of sustainability for Philips, and probably Ilias Lakovidis, representing the European Commission, will jump in at some point. Robert, you first. Give us a sense of the scope of the problem.
Thanks, Roger. Yeah, if you think about healthcare is where climate change gets a face, right? You already mentioned the enormous impact. I think climate and health are joined at the hip. So I'm really happy that this is the first day ever that healthcare has a day during a climate negotiation. I'm thinking about my own parents. Just celebrated the 90th birthday of my mum earlier this week. So the next heat wave could be fatal for people that are fragile. And then we are talking about Europe, right? So think about 4.5 billion people on Earth that do not have access to quality healthcare, but that are even more worstly exposed to the challenges of climate change. So we are at a very important point where we see that healthcare is not only suffering. The healthcare systems are overburdened, of course. So we have COVID, staff shortage, burnout, turnover, and so forth. But where we're also seeing that healthcare providers, doctors that have pledged to do no harm, understand they're actually contributing to the problem, and they can take an active role in it. Philips as a household brand, of course, but we have been changing a lot over the last decade, I would say. We are one of the leading health technology providers, so we're working with many hospitals around the world. And I'm very, very happy to see that doctors are really understanding the magnitude of the challenges and are trying to get organized to do something about it.
Can you talk a bit about the opportunities that might be seen for the medical profession?
I think opportunities and challenges go hand in hand. Why I'm saying that, if you think about the emissions, and I know that you would probably also talk about it, right? But in terms of size of the problem, the emissions of the healthcare sector are twice as much as the airlines or airlines and shipping lines combined. So on a global average is around 5%. Taking into account that half of mankind does not have access to healthcare, we need to decarbonize healthcare and make it more accessible. So if you ask me, United States is closer to 10%, in Holland it's maybe 8% or so. So that is not just a challenge, it's also an opportunity. If healthcare would stand up and lead, people trust doctors, right? That could be a massive change in behavior, and that could really be a substantial contribution to move towards more equitable and more sustainable societies.
So do you mean doctors to change their own lives and set an example, or do you mean doctors to work in such a way that the system changes and that improves for people?
I mean both. I've seen doctors march on the climate change in Amsterdam just 3 weeks ago with white gowns and talking and speaking up. I think that's important in a time where we have lots of disinformation and people being ill-informed, a declining trust in politicians. So if trusted people in their life, in their community speak up, I think that can make a change. But also understanding how you deliver healthcare. It's not just about energy-efficient healthcare equipment. It is also about thinking how to reuse material, how to design waste out of the system, how to optimize care pathways in such a way that care can be delivered with a much lower carbon footprint.
I mean, how would you go about doing that? That sounds like a massive agenda.
Yeah, I think that's where we have the panel for, so I would love to hear. My idea would be, and what I see working in practice is getting in a discussion about what is really material. If doctors and hospitals understand where the carbon footprint is actually, including patient logistics, including overtreatment, including what they buy and how they buy it, they can start to act. It's not good enough if the head of the hospital says we want to do something about it and appoints a junior staffer to do something on Friday afternoon.
Okay, so talking about logistics, to unpick those a bit, and don't worry about speaking too much. We've got a whole hour, so I sense you're reining in that you don't want to dominate the panel, but that's fine. You just dominate it for a bit, then somebody else will.
Equity, thanks.
It's okay. So talk about the logistics to start with.
Think about patients traveling to the hospital, back and forth and all around that. Just an example. If you plan healthcare in such a way that you can have your intake, your diagnostics, and maybe a start of a treatment on the same day, if that's possible, right? You save a lot of hassle to patients, which may be in ill health, typically also. You improve the patient experience, sometimes the clinical outcomes, right, by moving faster, and at the same time you reduce the carbon footprint of logistics. Just one example. I mean, you can think about, of course...
But hang on a second, that sounds easier said than done. You know, coordinating, say in the UK, which I know, for instance, coordinating GP schedules with hospital schedules is really, really problematic.
Yeah, I remember Kennedy at that point in time, right? He said, we are not going to the moon because it is easy.
Okay, fine. So what about the other things that you were talking about?
If you think about a carbon footprint of a hospital, so hospitals are typically 3 to 4 times more energy intensive than many other buildings typical in the city because of HVAC. There are a lot of equipment in a hospital that's actually heating up the air, which is not good for patients, so you have to cool it afterwards. So you have to pay the price. A leading German hospital told me just 3 weeks ago their energy bill will be 90 million euros for 2040. So there's a lot of energy going into the system. And so that's, I think, where you would want to start, driving energy efficiency in the hospital with energy efficient equipment, better designs and so forth.
I mean, but this all takes money, obviously, and capital expenditure to improve systems.
And the money is in the system, right? If you think 100 million for the energy bill every year, that is insane. If we find ways to drive efficiency in that and use part of that money by not spending it on fossil fuels and energy bills, but bringing it back into the healthcare system, what you can do in terms of improving patient care and making healthcare accessible. So there is money in the system, it just needs to be spent in a different way. I would say let's not talk about cost, but let's talk about investment and total cost of ownership, especially to society.
Well, how could you get hospitals to be thinking that way?
And I think that is a key question. And so I'm not in the hospital. I mean, as a technology provider, we can go and facilitate these type of discussions and create awareness. But I think it takes really doctors and care providers to think up and articulate that urge and think about what they can do, how they want to organize themselves. I think there's a role for governments also to think about how they can help hospitals to build these capabilities, for instance.
Okay, well, let's bring Ilyas in at that point. What can the European Commission do? What can governments generally do to try to help push this agenda? Actually, to start with, a more proper question would be, does the system understand that it needs to change?
Oh, definitely it does. But let me react. So first of all, my name is Ilyas from European Commission. I don't know if you even know what that means, just to make sure that people understand what European Commission means.
Thank you. I should have asked that.
Because now we are global, so we are not in Europe. So if you think of European Commission, there is kind of a proxy to federal government in US. But we are not a federal government. But it's like a federal government. When people think of us, so I always say the simplest way to think about it is we regulate. So we come up with the European laws and regulation that member states have to then translate to their own laws. We fund things. So although European Commission is getting 1% of gross national income of every country, which is several hundred of billions, we then feed back to a very specific policies, and health is one of them. Although Europe does not have a mandate to tell member states what to do in healthcare, we go through the window of innovation and technology. So I work in digitalization of healthcare. And the third thing is soft power of cooperation. So we bring people together within Europe and across. So we do the negotiation on behalf of Europe here at COP. So it's Commission people representing 27 member states. It would be 28, but
I'm so sorry.
Some fell for misinformation at some point. So we do kind of the bigger picture in Europe. So I'm personally in digitizing healthcare for 30 years. And for the last 5 years, I do also digitization of the environment. So looking at the environment and One Health, planetary health as well. Because if we as humans want to be healthy, we need to make sure that the whole environment is healthy. And you can look at it. Maybe the simplest way to look at it is if you think, what are the three major factors influencing the way I feel today? What is my health status today? What would you think? What is the three biggest factors that influence the way you are today?
Weather, like how it is outside, if it's raining or sunny.
So it's the nurture. I mean, what you breathe, what you eat, what you drink, what you smoke. I mean, the things that you do, a socio-economic environment, we call it nurture. The other one is your parents, so then nature, so predisposition, genetics. And the third important factor is the health system, how quickly they can get you in trouble when you're in trouble. So these are the three major ones. Which one is the least important? Healthcare system. Which one is the most important? Environment, nurture. Nurture is more than 50%. Where does all the money go in healthcare? So we do think of a system, but we put the money in the wrong place. So the system is geared so that most of the healthcare budget goes to the least important part and to the second least important, which means genomics research. It is so popular, it gets so much absorbed, and there's a lot of hype about genomics. But we're missing because there's no business case, and so we need Philips to actually think of business case. How to make a business case of bringing the environment to the healthcare. So if you really want healthy people, you want to make sure that your environment is healthy, and that is bigger than healthcare. Clean air is not healthcare system. It's mayors that have to make sure that the city has a clean air and clean water, because air and water is the biggest thing. Now, if you had to choose, you go to, let's say, industrial part of Germany that has the best hospital, but not as good air and water. Or you choose a country that has Bhutan, clean air and water, but not good doctors. What would you choose? So,
I would say, can I have both, please?
The idea is to have both. The idea is to have both. So one thing is, what can we do to optimize the healthcare system across? That means health in all policies means that the people that are environmentalists have to think like healthcare policy people, and vice versa. What just Robert said, if the healthcare is polluting so heavily, we are shooting ourselves in the foot. We make people sick through the environment. So we make actually people sick because we're polluting, and we're talking about medicines in the water. You know, when the water is treated, we have just issued a EU waste regulation, I mean wastewater regulation, how the water should be treated. You know what is the hardest part? It's not our excretions. It's the medication in the water that is the hardest part to get out of so it can be drinkable again. And there is huge amount of medication in the wastewater of the cities and communities. So that's really hard. Single-use devices, we don't talk about it. So when you say doctor, what doctor can do is to say, I don't want to prescribe single-use devices. I want to do something that is more ecological. So companies could actually provide that, but at the moment, they are excluded from European regulation.
Give us a bit of detail on that. What sort of things do you have in mind?
So, for example, diabetic patients, they do a lot of testing. In the past, there were devices that you can actually just change the tip. Now you throw away the whole device that measures you. I mean, it can be holters, it can be blood examination things.
Remember, that sounds like a policy going backwards.
What do you mean? So
well,
the policy today is that medical devices are not to be bothered by environmental legislation. So that means they are free to do what they want. That means that normally what they do, what do I make more money on? Selling more quantities of something. So let's do it single use. I make more money on that.
Robert, you want to jump in?
Yeah, I wanted to say, I think we are lacking feedback loops in the healthcare system that factor in the environmental impact. That's why it's so important.
Sorry, just hold it up a bit more. Hold your microphone up a bit more.
I think we need feedback loops. Healthcare has been optimized for clinical outcomes first, and secondly, of course, for the economic constraints. But what we lack is a direct feedback loop that factors in the environmental impacts. And then the system cannot improve itself if you don't see it. That's why it's important to talk about it and see doctors picking that up. And maybe on the reuse of parts, I mean, that goes for small devices like you described, Elias, but also think about these huge medical equipments. I mean, we make, for instance, MR scanners or CT scanners. They weigh tons. They are huge, and they have magnets in them to create 1.5 or 3 Tesla magnetic fields or so. It is wonderful if you can reuse these type of equipment and just upgrade them, for instance, with the latest set of sensors, detectors, softwares, and then put them out in the field to live another 10 years and reuse all these machines. So it's small and big. Yeah.
Elias, I think you were in full flow, but we interrupted you briefly.
So I want to kind of zoom out and give you a bigger picture of what is the most important factor for changing climate change. And then I will map it on healthcare, okay? So here it goes. There are 3 crises. We are here for climate change, but climate change is not the only issue. We have pollution and biodiversity loss. So all 3 things are equally important. Climate change steals the headlines, and the carbon view steals the headlines, but I want to tell you that these 3 are equally important, and they are interdependent. We look at often at and you understand this language, at the symptoms. So we look at the symptoms. The climate, the smoke and the CO2 is a symptom of something. And we try to treat the symptoms like we do in healthcare often. We're just trying to put, the antibiotics or penicillins and aspirins on the symptoms, that the driver of triple crisis is the way we run our economy. The non-circularity of our economy is the driver of this triple crisis. Because the business models, how people make money, how we run economy is quantity driven. More materials I'll sell in the form of car, furniture, mobile phone. It's the weight of the materials that makes money. It's not the serving of needs of people that makes money. You understand? You need a mobility, then I will make you feel that the only way to address this need is to buy a car. So we serve people proxies of the needs they have. You need light, so you need to buy every year another bulb. You need something, so we try to always think of a quantity of materials to be a proxy of your social need. And that's what we need to change. One way, a simple way, it's much more complex than that, is to actually go from products to services. I will serve you mobility. So I give you a way to get you from A to B. You don't need to own a car. I get you there much faster than a car would do. You don't need to look for parking. You can work on the way. It will be much safer and much quicker. So I can actually dress you with mobility rather than force you to buy a car. And that is true for everything in the economy. So if we can change the model and say, can I serve the people's needs with less materials, then I have a triple crisis that I can actually attack, because producing things I don't use or waste, it's emissions. Shipping them is emissions. Using them is emission. Wasting them and burning them is emissions. So you see, all these emissions are there because we are non-circular in our economy. Pollution, the same. I excavate pollution. I send pollution. I wasteland pollution. Biodiversity loss. To actually have all these materials, I have to cut trees. I have to destroy the biosphere of the earth to give you that quantity of materials. So that is the driver. What does it mean for healthcare? That means that I can serve the healthcare of population with much less materials, and that's drug development, medical device development, hospital development. All this is huge mortar and brick, rare materials in medical devices, scans, for example, and you have a lot of unnecessary trips in the patients. I give you another paradigm because I like paradigms and they stick with you guys. Patients today, when they are in the healthcare, is like traveling in Middle Ages. I don't know if you could imagine what it was to take a trip from Paris to Athens in 12th century.
Exciting.
It would be exciting, but how would you go about it? You would take a horse carriage, go from Paris launch to the next kind of Dijon, exchange your horses, and you ask the guy where to cross the mountain. Then you go to Alps, and there will be some knowledgeable guy that will tell you which passage to go through the Alps. Then you cross to Padova River, and there will be a guy that knows where to cross the river.
Elias, I have to say this sounds remarkably like this building.
But that exactly sounds like healthcare today. So healthcare today, you go to GP. He will tell you to go to that specialist. That specialist says, no, it's not me. It's that subspecialist. Okay. And you do a middle-aged travel, completely blind in healthcare system today. What did we do since 12th century in traveling? We have maps, we have satellites, we have GPS, we have roads, we have cars. I don't need anybody to go from A to B. All that knowledge is in the system. It's in the maps and it's in the infrastructure. Healthcare doesn't want to put any of that knowledge in the people's brain on the infrastructure. We make money by closing it and making you blind in the system. So what we have to do to make sure that we have personal health navigators have to be there. And we don't want to do that. And that can save a lot of frequent flyers to hospitals, which is emissions, which is a lot of cost, which is a lot of burden. My wife is a hospital doctor, and she sees patients that she should not be seeing because there is no infrastructure like in transport. We don't have Google Maps in healthcare. And that's what we're missing, and that is a big saver, and that's where digital comes. So I'm coming from the digital and data science to healthcare. And I see there are such opportunities to help people to navigate themselves, doctors to navigate. We focus on doctors, and they are much better now in terms of tools and diagnostics. So they have much more data in their fingertips than they had before. But we need the same thing for nursing, for health, and social care.
The problem is, I mean, I totally agree with you, but you have to take people's minds with you, and people's minds get easily influenced. So, for instance, what would it be, 20 years ago or something like that, I did a sabbatical at Oxford University, and I got research funding from the King's Fund, a UK charitable organisation, to monitor TV and radio news bulletins on health over a 1-year period. And what I wanted to do was to find that data of how often healthcare stories came up and what sort of stories, and map that against what real-life outcomes were. And it showed something absolutely crazy, like we had 1 death of necrotizing fasciitis. Killer bug ate my face was the headline, and there was just 1 episode in the UK, but I think it had like 7 or 8 stories about it. And then we looked at smoking and drinking and public health issues like mental health, for instance. And with smoking, it was like it took how many thousands of people to die to make 1 story about smoking. So, and that made a bit of impact, but it was only temporary. Then the Labour government came into power, led by Tony Blair. And they came up with this slogan, schools and hospitals, schools and hospitals. And I was saying, no, it's not actually, that's not what we want. We want education and we want health. But schools and hospitals were monuments that people could see, that politicians like concrete. They live on concrete. They think they'll get re-elected on concrete.
Personal, yes.
Okay, let me throw in another one. I'm sorry to confound you like this, but the Lancet, the UK medical journal, international medical journal, the Lancet, commissioned a friend of mine, an academic, to do a paper about whether or not it was more dangerous to cycle than to drive. And his conclusion was, it is much more safe, or it's much better for your health to cycle than to get in a car and drive. And the Lancet said, well, we're not happy on this data. We think it is better for your health. And the academic said, no, much better for your health. And eventually he won the day. Lancet published it. And what do we do now? A few weeks ago, Rishi Sunak is saying, I'm behind the driver and I want to help drivers in every way, and has dropped all his policies on walking and cycling. I'm sorry, that's a lot to answer. That wasn't really a proper presenter's question. That was a full intervention, but never mind.
Now, whose fault is it, journalists or politicians?
Yeah, well, look, absolutely. Journalists are a big part of the problem, yes.
Can I make a suggestion, maybe? I think part of it is also how the human brain is wired, right? If you look at how the human brain is wired.
How the human brain is wired.
So if you look at behavioral economics or social psychology or organizational psychology, so I think we need to act, for instance, on climate change despite our brains. We need to create conditions for organizations and decision makers to act more rationally by, for instance, modeling complex systems.
Do you know Mary Baker? You must know Mary Baker. She was in the brain research. Anybody knows that name? She's a famous UK kind of researcher. And she published a paper a few years ago saying the 6 things we learned that don't work, changing people's health behavior. So after 40 years, what we know are 6 categories of things that don't work. We still don't know how to change people's behavior because we are very irrational.
So what are the 6? Or 5, or we'll take 4. It's early in the morning. We'll take 3.
For example, these kind of leaflets on that put one simple message like the cigarettes. We made a law in Europe to put a picture of a lung cancer on a cigarette box.
Yes.
So this type of generic messages don't make a difference. The putting tax on alcohol don't make a difference sometimes, So there are some short-lived, they spike as an impact and then they go away again. So this kind of policies that I treat everybody equally, and I will take a rational message. So what doesn't work is information to patients. So many cancers because of smoking. That's why you should not smoke does not work.
But it means we should learn from that. For instance, also for climate change.
Yeah, exactly. So what I'm bringing that knowledge, because the climate change is they are novices. They are still in infancy compared to what healthcare research has done. So because being in healthcare now in environment, I'm taking a lot of knowledge from healthcare, trying to teach and make them skip some of the traps that healthcare fell into. So the environmentalists don't go into. I give you all the science about melting ice, temperature rise, all the things that you just mentioned before will not make people change behavior. I know that from healthcare. So all the science of how the climate is changing will not change people's behavior. What we need to go back, remember the economic paradigm? We need to give products as a service to people that are cheaper than alternatives. You want to make a change? You go through sustainable business model and make that cheaper. That's the only way that we can tackle climate change, not through science and journalism.
I just wanted to remind us that Lauren is in healthcare education.
That's fine. I wanted to just see if we could get agreement between you guys first before we bring in Lauren.
No, but at the end, it's about education. But there's so much on the shoulder of education that we should not put the responsibility on the education part, because that's what people do. Education will solve it now.
I'm puzzled because I thought you were saying that information wasn't the issue.
I know.
What's the difference between information and education?
Information about climate science and educating people that the big difference is that I need to change my, that circular business model can get me better outcomes while I benefit from it because it addresses my needs, that's education.
Right. And how can you embed that into the thoughts of all the hundreds of thousands of medical professionals in the UK and those people in business who serve them?
Well, my personal story is when I tell that to my wife, she says, just go to hell, I have patients to see, I have 2 papers to write, and I'm managing because she's the head of the clinic.
That's not very
so don't bother me with the environment, that's somebody else's job. So we have to embed it in a way that in order to manage patients better, you embed in the design of healthcare system and the patient care and social care also the environmental aspects, but it cannot be add-on to already busy doctors. I mean, they feel like the next thing they will ask us to do is to clean the hospital before we leave because they feel so stressed.
Yes. Robert?
I agree, and I would add to that one way of making that click is by showing doctors that there is an alignment between clinical outcomes and environmental outcomes, right? So that what we talked about earlier, if you are able to optimize care pathways in a hospital, and then you see if you don't have to scan a patient twice because the image quality is good at the first time and you can make the right diagnosis, you save a lot of CO2. So better clinical outcomes, less hassle for the patient, and lower environmental footprint. So these things need to go hand in hand also in the heads of the care providers.
Yeah, but it's so hard to change the bureaucracy, isn't it? My wife went in for some blood tests a couple of weeks ago, and then the following week she got asked to go in for blood tests. And she said, look, I've just had blood tests. Just use the ones I just had.
Don't trust the machines. The calibrations of 2 hospitals will not trust each other. That we need to break.
Well, how on earth do you do that? I mean, I'm completely on board with you, but how do you do it?
Part of it is making hospitals work together. For instance, in Amsterdam now, for the first time ever, there's a memorandum of understanding between the 3 big university hospitals to give access to clinical patient data for research purposes with consent of the patients, of course. That has not been possible 2 years or 3 years ago. So hospitals need to talk to each other. And there are a lot of adverse and perverse incentives in the system also. If you get paid twice for doing 2 times the test, I think there's a certain temptation to be on the safe side and to do 2 times the test. I'm not saying the financial interest is driving it. At least it's not discouraging that kind of. You see totally different behaviors in Kenya, for instance, also, right, where people don't have more than $3 to pay for a doctor's visit. They think twice where they spend these $3.
Right, and with a free-to-access healthcare like we've got in the UK, there's an incentive for people to take more of it, or an insurance-based system, indeed.
The imaging system already did that at the regional level, so you don't think that the imaging is almost concentrated and acts as a virtually serving many hospitals. Same could be done with the labs and standardization of the labs. So there must be kind of virtualization and standardization across the labs, so everybody trusts any lab because they have been kind of working together. Because today it's so divide and conquer. I mean, I like this lab because plus more tests brings more money. So you also, it's kind of a 2 buns of a hamburger. You need to change the way that the labs work and get standardized, but you need also to come in with a governance that is more like the guidelines from NHS, for example, or from the national or regional government to incentivize not to multiply too many tests.
Yes. Do you feel like you're winning on this argument with European nations?
Well, it's a tough thing. But we don't, as a Commission, we don't have a power to tell them that. But we actually trying to expose that.
You have the power to influence, obviously.
We have power to influence, and we have a power to kind of go through the medical device standards. So kind of a technology windows. That's how we're trying to do it. So the technology is there to virtualize and to make all the labs or all the hospitals to be like one on imaging or labs and others.
Yeah. Okay, sorry, do you want to come in and add?
Yeah, I wanted just one sentence or thought on that. I mean, of course, the European Commission cannot interfere directly in the healthcare systems, right? But there are many ways of influencing Elias. Having, for instance, and maybe having national coordinators that facilitate decarbonization of healthcare at a national level and it could be somebody from the field, right? Would that be an idea, and maybe something that the European Commission?
What we have a mandate is climate change. So we do have a mandate. So through the climate change, which we have the power to regulate, we should now include healthcare, which we're excluding all the time. So we have excluded the hospital waste. So anything that is hospital waste has to be burned. But how many SMEs, companies are saying, can I have these plastics that you're burning because they were used in hospitals so I can make construction material out of it? Not forbidden. The regulation says they have to be burned. But that's valuable material for me. So we need to break the law. So there must be a push by the industry to the regulator saying, I want that material, don't burn it. And I can make it something else than hospital medical device. I can make it construction material.
Yes, I mean, there are clearly dangerous materials that are wasted.
No, just because they came into a contact with a patient, they have to be burned. But we can sanitize, we can, treat them at the molecular level. You can actually melt some of these plastics and metals and create something else, not a medical device.
What sort of things are you talking about?
I'm talking about tubing in the hospital. There's a lot of tubes for people that are on respirators. It's kilometers of tubes per month that are thrown away and burned that can be used as plastics of these tubes to another type of use.
Wouldn't people fear a risk from contamination, say, with people with lung diseases, and then they might spread lung diseases?
So they have a way to actually treat it in a way that it can be a safe construction material.
Right. Okay, let me bring in Lauren here, Lauren McCowan from SEEDS, which is a non-profit specialising and training in medicine. What do you think of what you've heard so far?
Well, so I think it's fascinating.
Just take your microphone up a bit.
Yeah. Is that okay?
Yeah, that's good. Yeah.
So I think this is fascinating for me because we work in very, very different health systems. And so I'm learning a lot and taking in, I think, a totally different end of the climate health nexus from where SEED Global Health normally works. And so this is all really, really interesting to think about in the context of the hospitals in which we work. I'll take you on a little bit of a journey to a very, very different system. SEED Global Health is a nonprofit that works in Malawi, Uganda, Zambia, and Sierra Leone, all very, very different contexts. But the region in which we work, climate change is having a vast impact on the health system in a very different way. And so these conversations are very, very relevant to those systems. I empathize with your wife saying, I have patients to see. I can't be thinking about climate change. So the healthcare workers that we train and support at SEED Global Health, I think, experience this nexus in a very, very different way. We did not start working on climate as a matter of, look ahead strategy necessarily. The health systems in which we work and support came about this really by necessity. They were seeing historic bouts of cholera in Malawi this year, exacerbated by tropical storms, more and more outbreaks of dengue, of malaria, of Ebola in Uganda, where our team this year fought an Ebola outbreak in partnership with the Ministry of Health. They're seeing increasing rates of preterm birth and preeclampsia due to rising heat and increased water salination. There's a study that just came out in Bangladesh tying the increase in water salination that's related to climate change to preeclampsia and preterm birth, specifically in Bangladesh.
Seen that, no.
It's fascinating and terrifying. And so I think for us, one of the questions that we're asking currently of the system, in a system where there are just too few health workers, right? The region we work in carries 24% of the global health burden, sub-Saharan Africa, with just 3% of the global health workforce. There's simply not enough doctors, nurses, and midwives to even greet a patient at the door of the emergency room, to triage, to get that patient to where they need to be to seek appropriate care in the public hospitals in which we work. So SEED is really focused on training and supporting an emerging generation of physicians to be able to not only just address the normal kind of day-to-day health system needs, but really to prepare for the climate shocks that are already here and the climate shocks that we will continue to see in these systems. And so I think for us, where we've seen public-private partnership with organizations like Philips, companies sort of across the healthcare space and in other sectors, be incredibly helpful is actually in bridging the gap for these countries, often in whether that's providing low-cost medical devices, vaccines, access to a philanthropic capital, frankly, because domestic GDP in the countries in which we work is just not sufficient to cover the healthcare burden. So I'll give you an example. In Uganda, where Seed Global Health is building out the first ever cadre of emergency medicine physicians. As of 5-6 years ago, there were no public sector emergency medicine physicians, not one. So we're working with the university there to train, to build the curriculum, to train the faculty, to support the Ministry of Health and their priorities in building out emergency medicine. And so in Uganda, the entire GDP per capita, $880 US dollars. In the US, we spend $13,000 per capita just on healthcare. And so even if Uganda spent its entire GDP on health, they would have 16 times less GDP to do that per citizen than the States. And so there's a huge push, understandably, on domestic financing. How can Uganda itself put more money into the healthcare system? They're doing what they can. But we're going to need to invest in these healthcare systems to be able to help them bridge the gap and really absorb climate shocks that are coming their way, landslides, floods.
Give us the details about how you might envisage doing that. So I'll just say for the record, how would you envisage doing that?
Yeah, so I think, we start with, we simply need more healthcare workers. So our part of that is training and supporting them, is getting them through programs, developing programs in the first place, making sure that they exist in deep partnership with the Ministry of Health. I think for us, it's critical that these investments and that the support and that the partnerships are very driven by our Ministry of Health partners. They're our boss. They tell us what we're doing, what we're focusing on, and so not coming in with our idea of what's needed in a health system, but rather saying what's needed. We've spent a lot of time with our Ministry of Health partners at COP this week, hearing from them. There are very, very real concerns about the system and the financing that's going to need to flow into this space to bridge this gap. There's actually some really promising news this week. We saw a loss and damage fund approved moving forward. There are a number of other funds that have been announced, which is fantastic. So one of our answers would be more financing. I think the second answer within the kind of financing question of all of this is that financing has to actually be available. One of the biggest questions I got this week, and I've been a fundraiser the better part of my career, so I get this, was how do we actually access this fund? Do we have the staffing to be able to even put that proposal together to access these giant global climate funds that are coming out the door? What does that look like for a country like Malawi, where the Ministry of Health staff is already overrun, doing as much as they can to support the health system, and doesn't have time to put together an incredibly costly proposal? And so I think part of this is also...
So what's the answer to that? I mean, you're identifying a really potentially very serious problem here. Countries that are so poor they can't afford to ask for more money.
Yeah. We have to bridge the gap globally. I think there's a vast inequity in the way that we are experiencing climate change. Most of us in this room are experiencing a very different COP than a lot of folks at COP. The countries that emit the least are being impacted by this the most. And so I think there's a huge role for private sector, for philanthropy, to play in helping bridge that financing gap. And I think it's not just for, there's the social benefit, right, the feeling of helping out, of being a part of that, but I also think this is about our collective future. This is about national security, it's about global security. If Ebola cannot be contained in Uganda, as it was this year, miraculously, hopefully you didn't hear about it too much in the headlines, because within a matter of 3 or 4 months, the government had contained it. But if it hadn't, where are we then? Okay, and so that, I think for us, it's stepping into that and understanding our kind of collective responsibility to finance that, even if it feels very far away. Understanding that connectivity.
Sounds very present. I read one analysis that the loss and damage fund was less than the value of the Manchester City football team, which sounds funny, but actually is not really very funny at all. Ilyas.
Yeah, I just wanted to react. So first of all, she gave the best example why nurture is the most important for people in Malawi and Uganda. Much more important than the health system that doesn't exist, or they don't even think about their genetics. So the problem about funding, I talked to World Bank. We have something in EU that we came up with, it's called EU taxonomy. What does it mean to invest in sustainability? And there are some activities that are aligned. And many private and public investors say, I want to fund sustainable things. So we need to create the conditions that the things you're working on are on the menu of sustainable finance. Because then that releases a lot of funds, first. Second, I work with local governments. They have no capacity, they have no staff to fill in applications. So the capacity of people to understand how to get money and spend them correctly, because it's a risk about when you're in the business of spending money, you're afraid that you do something wrong. So that people don't exist on a local setting in Europe. You can imagine in Malawi. So we need to bring some kind of a simple guidance and capacity building to local authorities in Malawi and Uganda that can fill in the application to fill in that I am sustainable finance by doing emergency medicine, because that's about resilience and climate adaptation. And I can spend the money. You bring the financial sector of Uganda to help these people to spend the money correctly. So that capacity has nothing to do with healthcare, but that's the biggest decisive thing for healthcare.
It sounds a bit as though you think that climate change as an agenda item has pushed other agenda items out of the way. Is that an exaggeration?
In a way, the renewables take much more importance today, because that's a sure thing of spending sustainable money than healthcare. So we need to rebalance that. So instead of all the money flowing to renewables in Uganda, to flow into healthcare system and make it sure that this is climate agenda.
Yeah, I think it's a really good point, and it's I think for context, often exactly as you're describing, there's so much focus on the mitigation side, incredibly important. We have to focus on that. But when that's brought, say, in the context of COP, to someone from the Uganda, the Malawi, the Sierra Leone delegation, there's an offer of a solar panel on a health facility, fantastic. There's a question about waste management in the facility, fantastic. There's one nurse seeing 100 patients, and so that's got to be, into your wife's perspective earlier very much reminded me of, I think, how our healthcare workers would respond to this. I also think it's really, like, for them, it has to be, at the end of the day, about strengthening the healthcare system in a way that they can actually get it operational, and be able to then take on the next question about climate. They're just not, like, they can't bear to have that conversation because they're moving so quickly through their day that it's just not a viable reality.
Brain space, yeah. Robert?
Yeah, maybe coming in on that, I think that's an excellent example how healthcare can get us out of this carbon short-sightedness, right? I mean, you know the term carbon myopia. We are not going to solve climate change by just focusing on carbon. So, for instance, a health-centric approach to attach or to tackle climate change would bring a lot of different stakeholders by showing them how climate change, which is a long-term intangible kind of thing for many people, affects their daily lives, get them engaged, and really drive change today.
What can a firm like yours do?
We do a lot of things. Of course, first of all, trying to get our own house in order. So we started reducing our operational carbon footprint. I joined Philips in 2008, and we introduced the carbon cost curve, reduced our operational carbon footprint with more than 80% in the next 6 years. Since 2020, we operate globally carbon neutral, so we have our own wind farms, solar panels, whatever, 100% renewable electricity. But that was only the first step. I think if you want to scale it, we can help hospitals decarbonizing their supply chain. So we have about 15,000 bill of material suppliers upstream of Philips, right, where we source components, materials, and so forth. We have been sharing what we've been learning from our own journey with them. And 3 years ago, we reached out and said, guys, we have science-based targets, scope 1, 2, and 3. We want you to also adopt science-based targets, because that's the only way to drive accountability, which means basically nobody is going to emit more carbon than would be compatible with 1.5 degrees maximum global warming. So we set ourselves a goal to get at least 50% of our 15,000 suppliers to also commit to science-based targets by 2025. That was insane at the time. Nobody knew whether it would be possible. Last week, it was 46.6% of our global supply base that has already committed to science-based targets. So that's very encouraging. And that's upstream. I think the most important thing is what happens in the hospitals. So we have been really aligning our entire innovation roadmaps with these science-based targets. So really saying to an engineer, to strategy folks, to whatever, say, these are the requirements of the healthcare sector for the next 5, 10, 15, 20 years. Think about it when you develop the next generation of MR scanners. And then, of course, going into hospitals, facilitating discussion and asking care providers to please step up, get organized, articulate what you need. Think about green purchasing, because then we can deliver. We have the innovation power, but doctors need to tell us that they want it and what they want.
Thank you. Let me ask any of our audience if they want to throw in a quick question or a comment. Anybody want to talk? Could we get a microphone here? In fact, maybe we'll take both and we'll see if we can be quick.
Thank you so much. It's really interesting discussion. The question I have, so we've heard about the circularity and the business models, and healthcare is, I guess, has a long way to go. But do you have any industry other than healthcare that has gotten it right and is doing it that we could learn from?
Ilya, briefly.
There are some emerging. So in every industry, there are the new beginners that go into product as a service. And it can be a reseller like Decathlon. I don't know if you know what Decathlon is. It's a big shop that is sporting goods. Yeah. So they're going and they are piloting now the new way of doing things, that you pay a small amount per month, 20, 30 euro, and you can have 500 euro of equipment anytime you want, any equipment you want. You can go take skis in the winter, rackets in the summer, camping materials in the fall, and you can exchange that. So as a service. So they're giving us services. They're not selling to you. So that is fair for poor people because they can afford the 20, 30 euro and have still access to these things. It's good for the materials because if you buy 4 pairs of skis for your family or bikes, I guarantee you 99.9% they are parked in the garage. So that material is not utilized. It's kind of waste. It'll sit in that garage until you have garage sale. So there is a much better material utilization. It's much fairer for the people. That's kind of a reseller. We have in clothing material, so there is a new wave of new generation of entrepreneurs that take old recycled material and create new clothes. Or you go into renting. So that's very popular now. So in textiles, it's emerging. In cars, Volkswagen is thinking now, I may not sustain my business by selling cars. Let me sell service. So they are establishing in Hamburg mobility as a service. They will deploy ultimately by 2030 10,000 autonomous cars to take people around. So they will make money not by selling cars, but by selling services. So it's happening a little bit everywhere, but it's not mainstreamed. Okay, so my idea for Philips is to go into whatever they sell to be as a service. And so they take it back, refurbish, and give it another life.
Yes, we offer imaging as a service, we're offering patient monitoring as a service, and more than 20% of our global revenues come from circular products and services already.
Thank you.
It's there.
Madam?
Yes.
Briefly, if you will.
So I feel like that I'm listening to my nephews talk about how bad their parents are. As I mentioned, I'm with Common Spirit Health. We're one of the largest private not-for-profit healthcare systems in the United States. We're in 24 states, 150 hospitals. We have a net zero commitment by 2040 with an interim goal to cut our operational emissions in half by 2030. With all that said, we have a plan. There are so many levers to how we're going to get there. I have so many comments to make, but I think to the point of supply chain, our total greenhouse gas emissions, 75% is attributed to scope 3. Basically. So to the point of how unimportant hospitals are and their emissions, we're going to do our part to get that 25% to nil, right? But we need partnerships, right, to be able to get there. And we are working with our 100 top vendors right now to encourage them to go net zero. Let
me stop you there. I'm sorry,
Yeah.
because I've given a hard deadline and we're already slightly over it. Robert, last thought.
No, I just wanted to thank you. I think that is exactly what's needed.
But to the point, I mean, in Europe, we couldn't have gotten here without partners. I don't know if you know Healthcare Without Harm
Of course.
or Global
We work closely with them.
Hospital. Please, let's work together because I think we can get there together.
I'm going to suggest you guys meet outside that door for a chat right after this meeting.
Thanks so much.
Can we please thank our panel? We have to move on, but it's been a good talk. Thank you.